They go to doctors and they're not getting great advice, or, they're wanting to see changes or not seeing changes. The advice they're giving them is contradictory to what someone else is saying. It brings up that question of how do doctors decide what type of care to give you?
Even myself, with all my knowledge and understanding, I'm still brushed off by doctors and practitioners.
I saw this on my lab work. I want to also have this in this test, and then go, you're fine. You're just tired because you're a mom. That's normal in this time of life. And you're just like, this was the biggest waste of time, and I waited 6 months for this stupid appointment. So what can we do to try and help prevent medical gaslighting? Hello, everyone, and welcome back to the Metabolism and Menopause podcast, where we help you understand this new body of yours. Now that you've gone through some hormonal changes, or maybe you're past menopause at this point, we know that those old fat loss strategies just really aren't cutting it anymore. So it is time to learn how to work with your body, not against it, so you can unlock your fat burning pathways, improve your energy and confidence again. So today I have the wonderful Coach Brittany, and we are going to be talking about evidence-based care and what that really means, because we've all had our journeys. Brittany has been on quite a recent journey, so we're going to share a little bit about that today. But the reason we want to talk about this is because we hear from women all the time. They go to doctors and they're not getting great advice, or, they're wanting to see changes or not seeing changes. The advice they're giving them is contradictory to what someone else is saying. And so it brings up that question of how do doctors decide what type of care to give you, right? When you go to a doctor for a visit, how is it decided, what type of treatment that you're going to get? For some people, this can be an incredibly frustrating experience. You go to the doctor, someone who you trust to help you figure out what the heck is going on with your body. And it can be a mixed bag of feelings, right? Maybe some relief that you were going to go get some answers, potentially some fear that you're going to be dismissed and you're not going to have some answers, frustration that you feel unheard, not seen, not informed. So how does a doctor decide what type of treatment would be best? And how can we make sure that you are getting the best type of treatment for yourself, but also ensure that you are truly being heard? Because let's face it, we get sloughed off all the time where it's like, oh, of course you're tired. Oh, of course you're going to be stressed. Oh, it's just menopause. Oh, it's just PMS. No. We're not doing that anymore. So Britt, I'll let you kind of start with a little bit of information here for us.
Yeah. So, this is a really important topic. This is something that I am super passionate about. It's something I talk a lot about. I've been in women's health, hormones, nutrition movement for a really long time, over 20 years. And even myself, with all my knowledge and understanding, I'm still brushed off by doctors and practitioners. I'm still not listened to. I'm still gaslit all the time. So it's not like it's happening to people who have a really base knowledge or don't know very much. It's happening to all of us, right? And it's really, really frustrating. And it makes me really angry. It makes me angry that it's still happening today. I can understand 50 years ago maybe, but we have no excuse for this to continue to happen on a daily basis to specifically to women. I've talked a lot about my background and kind of all the things that I've done. And I have been a birth and bereavement doula. I was one for 11 years. I still consider myself one at heart, and so not only did I support families through pregnancy, birth, early postpartum, and through the process of loss, I also co-wrote and co-created a training and certification for other doulas. I put that out there. I ran that for 6 years. And the one area that I was super, super passionate about, and whether that was teaching my clients, teaching others who were looking to become doulas, was teaching them about what evidence-based care is, what informed consent is, what that truly, truly means, so that they could walk away with an understanding of that. And unfortunately, this isn't taught to many people. And women especially are not taught how to advocate for themselves. We're kind of like, oh, okay, thanks for telling me. I'm being dismissed. I'm being belittled, but okay, thank you. I'll just go and, question it later, and then question myself later, right? And we don't know what to look for as good medical care, and we don't know how to have those conversations. And if you take one thing away from this conversation that we're going to have today, I want you to take away that being able to say no makes that yes that much more powerful. So being able to say no in any situation, but specifically in medical ones, makes that when you consent and say yes, you really are consenting because you are aware of all of the options, right? We all have the right to care that is supported by evidence, that's in line with our desires and our beliefs, and given to us in a way that we can understand the pros and cons and options. It's not going over our head. We're not confused. We're not confused into choosing something, but we're really understood.
And this is why we're so big. Like, we do so much testing in-house. We're going to be doing lab work right away, which is awesome. But being able to explain all of that to a person, like, what does this actually mean? How does this relate to the symptoms that you're experiencing? Let's look at the full picture. We're not just going, oh, you have this number, here's the medication. We're not doing that. That's not helpful, right? You are more than just a number on your blood work. And so first, we need to have a little bit of a history lesson on medicine and best treatment practices. So prior to the 1970s, most treatment and care was based on physician choice and their own personal assessment of the case and patient. There wasn't much interaction between doctor and patient. Patient would come in, they were told what was wrong with them, not really listened to, given treatment, and sent on their way. These treatments were typically based on medical therapies that had been tried on a few patients, but were not typically sound, as you can imagine back then, right? This practice was entirely based on clinical opinion, experience, and unsystematic observation. So let's say a doctor decides to manually remove a woman's placenta. It goes well, so he does it with all his patients. 200 births later, he's saying this is a safe and beneficial practice. But 200 is a pretty small sample size, let's be honest.
And we have nothing to compare that to, right? Like, there is no comparison. It's just like, this is what I did and it worked well for me, or what I considered well. And it was 200 people, and boom, this is now something that I do and I recommend it to everybody, right? So carrying on with kind of that history of this is in the 1970s, there was a doctor named Dr. Archie Cochran, and he started to promote the use of these randomized controlled trials, or RCTs. And this was kind of the inception of this evidence-based medicine. So Dr. Cochran criticized the lack of reliable evidence behind many of the commonly accepted healthcare interventions that were being used. He believed clinicians should utilize procedures with most proven evidence of effectiveness. What a shocker there, right? And Cochran's promotion of the use of these RCTs provided the foundation of this healthcare decision-making that evolved into the evidence-based medicine movement. So the advent of this movement kind of facilitated the development of other types of review systems, right? Systematic reviews, meta-analysis. These research methods are used by researchers to identify multiple studies on a topic, select the best ones, and then be able to critically analyze that data and then synthesize all that data into a usable form for physicians to use with patients, right?
So this only happened in the 1970s, you guys. Like, that's only 55 years ago.
So not
that is
ago.
Not a long time.
No.
That is crazy.
Right? So we were using the other form of medicine where some doctor just decided to do something before. And this is when we've made that change, right? So not that long ago. And then in the 1990s, the term evidence-based medicine was introduced. And there was kind of that clear definition given to it by Dr. David Sackett. So he termed it the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. So he recommended that clinicians formulate a diagnosis based on evidence and research, and then it should also incorporate individual patient preferences, values, and beliefs into the process. So this is where it was very, very different. So I want you to kind of let that sink in for a second. True evidence-based care allows for the patient's beliefs, desires, and preferences and values, right? Essentially, evidence-based care is when you combine these best research evidence with the care provider's experience, with what they've dealt with in their practice, right? And you as a patient, what your values and desires are. So that includes your intuition. That includes clinical expertise. It includes the use of evidence from all that clinical research. And you have to ask these questions like, what is proven to work best? What is the most up-to-date medical evidence, including information about risks and benefits? And remember, like, we need to know all the information. The risks and the benefits need to be told to us to be able to fully make an informed consent and choice, because that's what that entails, right? Knowing the risks and benefits. So this is when a person must have sufficient information and understanding before making decisions about accepting the risk. And remember, the ability to say no is important when it comes to evidence-based care and informed consent, because remember that no makes that yes more important.
And so this isn't just like medical procedures, you guys. This isn't just medications. We're talking also about nutrition, lifestyle, supplementation advice that you get from naturopathic doctors, that you're getting from your doctor. What is the risk if I do this long term? I am working with someone currently right now who was advised to eat a 900 calorie diet and has been doing that for 2 years. Never were the risks mentioned about what can happen to your body if you eat that low calorie for too long. And unfortunately, a lot of the times people don't know, because a lot of doctors are not trained in the nutrition side of things, right? Like there's a reason that we work with so many people, and we are doing the certification and stuff, because this part is easily the most important thing to me. I mean, we just had a meeting with a client last week. Like, our priority is do no harm. That is rule number one, ethics, morals, everything, including nutrition and lifestyle advice, because that can change the trajectory of your life forever. We know, like, things like eating low calorie for too long, following the wrong diet for too long. Like, people do keto and they're like, oh, it works. But it's not meant to be long term, because you know what happens? You make yourself insulin resistant. You can actually cause hypothyroidism from under eating carbs for too long, from fasting for too long. People are like, oh, but it's working. And it's like, you're not supposed to be on these things forever. This is where diet variation is important. Learning how to eat quote unquote normal. Like, we can use tools at certain times, but this is where a lot of people get it wrong. Fasting isn't supposed to be a lifestyle. Keto isn't supposed to be a lifestyle. Carnivore is not supposed to be a lifestyle. And so that's the issue that I see a lot, even just in the coaching space, let alone like healthcare, is that people do not talk about the long-term negative side effects, because we know if those things happen and then we can't get into that fat burning pathway later because we've over abused it, and now we got to do such extreme things that we can't. We have to take time to heal the body. That causes disease progression. That causes an increased risk in certain cancers. It causes an increased risk in cardiovascular disease. It causes an increased risk in diabetes. And so this is something that I'm so big on mission right now, is educating other coaches not to take years off of someone's life down the road because they're trying to get this crazy result right now by doing it the wrong way, because that is not do no harm. That is the first ethical rule for everything. And so this is why this kind of stuff is so massively important to us. And then if we have a client that like wants to drop calories, we actually have to get them to sign and say this is going against our advice for like liability reasons, because it is dangerous to do such a low calorie state. And so we have these conversations with clients where we cannot do this. Like, even supervising you, it is not wise. We have to outline all the potential risks, and it's not to scare them, but it's being very upfront with, these are the potential risks if you continue this way. Should you want to do that, I can't control what you do, but like, you have to accept like, this is like the potential risks. We have to get them to sign off on it. Again, we've had to do this maybe once, but like the conversations do happen all of the time because it is so important. So when we're talking about like, what is evidence-based care then? Because you hear that all the time, right? Evidence-based, evidence-based. This means having a full, accurate information to help you make decisions. It means being cared for by an experienced care provider who pays attention to evidence, including clinical evidence, right? Care that is tailored to your preferences and your values. Like, we have certain people who like don't want to eat meat. Okay. We can help you get to where you want to be without eating meat, right? That might mean some extra supplementation, very specific foods that we need to make sure are in there, right? But that matters, right? Remember, there are two important parts to keep in mind here. Evidence alone is not enough to make decisions about your healthcare. Lab work alone is not enough to make a decision about your healthcare. There needs to be a conversation. There needs to be more questions asked. That's why even when you ask us to calculate your calories and you hop on a call, What are the questions we ask you? How's your sleep, stress, energy, digestion, past diet history, past activity, any symptoms that you're experiencing? How are your hormones at right now? All of those things, because all of those things are going to come into the way that we come up to the decision of how much food does your body actually need. Because if we give you the wrong number, then we know that it can cause harm. And so evidence alone is never enough to make a decision about your healthcare. There are levels of evidence to guide decision making. So what are these? One, how do you find evidence-based education, right? Randomized control trials are great. It's a random assignment. It's like flipping a coin. This is what we did when I did my master's research, actually was a randomized control study. It's like flipping a coin, an experiment. One group receives usual care or placebo. Another group receives a new treatment. You compare the two groups before and after. Random assignment controls. There's blinding sometimes as well, right? Where the researcher doesn't know if they're in one group or the other. So there is no possible way to really know or anticipate what the outcome is going to be for each individual patient because you literally do not know. That is good. It's completely unbiased. Then we have systematic reviews. These are combined from different studies. So if statistics run like a meta-analysis, that's what you hear about lots, right? So there's most famous reviews are going to come from the Cochrane Library. Unfortunately, they only review RCTs. So that's something to be aware of because there's other studies that you can do. But basically, it's like a study of all the studies to summarize the findings of all of them. Is there trends? Because there's always going to be differences in studies based on different things, right? We know there's confounding factors. Like, did they control for age, height, weight, health history, right? Sex and gender. You can't compare fasting studies from men to women who are young versus women who are 50, women who are like hormonally normal, right? Quote unquote normal versus, does that person have estrogen dominance? How do we know? Did you test for that? How do you know that doesn't interfere with the findings, right? Like there are so many things that can also address that. So when I was in grad school, there was two of us and my friend was the stats queen. Like when we would go to conferences, she would grill people on the types of statistics that they chose because different kinds of stats give you different kind of answers, significance, all those kinds of things. For me, I was the queen of confounding factors. People hated when I was reviewing their studies. So I'm like, did you control for this? What about this? Age, height, like hormonal status, were they on their period or not during this time? Like were they trained, untrained? Like where did they live? What was their background? Have they had trauma? What's their sleep like? And people would get so mad. And I'm like, because if you're going to make very strong, outlandish claims, you best make sure that there is no other room for a reason that things can change, right? And so this is something you have to realize too in studies is that those things usually aren't controlled for. And typically people who go in studies are quote unquote healthy, typically in a like higher privileged, like financial bracket. There's different things there too. So does it like work with you and your demographic, right? Britt, I'll let you take it away with some of the other research studies and ways that we can look at evidence-based.
Yeah. So I just want to mention, like, if we think about these studies that we're going through, I want you guys to follow it along as like, we're going from like top tier and then we're going down the list as to like kind of the lower tier of education and studies and evidence. Okay. So the first two that Steph just mentioned are like the top tier. Those are the ones like we put a lot of weight in those because they are really well done, less bias, a lot more information. Right. So another one that we could look at is observational research or like prospective studies. So, this might be like following a woman through pregnancy and birth, right? This is, these are fairly high quality. They may or may not have like a comparison that you have available to them. There's usually some case control studies. They form like a match or comparison group so they can kind of compare the two groups together. And then there's like retrospective studies. So like looking back on all of that data, like what happened, what can we compare, what can we look at? So looking backwards in time. But there is limited data available to that. It's not as much as like those randomized controlled trials and stuff like that.
Yeah, it's harder to do like cause and effect for those. It's more like a correlation or like this likely leads to this, but it's not like definitive, this causes this. Or like if you're doing this, you have increased risk of developing XYZ, right?
Right. Yeah, you can you can look at it and go, maybe, right? Possibly, but we have no like real direct evidence, right? And then there's case reports. So kind of like the lowest form of research evidence, right? These are like useful for learning about like rare events. They could be good or bad quality. You could also think of it as kind of like things like letters to an editor or anecdotal, right? Anecdotes, I think, have a really important role, right? Especially like when I talk to clients a lot about when I was doing labor and birth support, I could tell them like there's anecdotal evidence for this. There is no research on it, but years and years and years and years and years of anecdotal evidence can show us that yes, for the most part, this is safe, effective. This is the kind of the thing that it shows, but I don't have an actual case study. There's been no scientific support of this, right? And then, we have to take into account like your doctor, your OBGYN, your midwife, whoever you're working with, we have to take into account their opinion. Technically, it is considered evidence, right? It is the evidence that is most likely to be biased because it is their own viewpoint. So it could be right. It could be wrong. It isn't fully evidence-based, but it is part of how we make decisions.
When we're looking at like doctors, even coaches, those kinds of things, right? Like, technically evidence-based. However, you have to ask them like, how often do you research this stuff? How often are you like re-educating, right? Because some doctors don't give a crap about hormones, women's health, right? Or nutrition. So they're not up to date on those things. And it can take like a study that comes out today can take 25 years to get put into practice. And so then we're way behind, right? Like we saw birth control. Now all of a sudden people are starting to think twice about it because they're like, oh, wow. Now infertility is really high. There's more instances of PCOS. We're seeing a lot of like progesterone issues, estrogen dominance. And we're seeing like there's a huge like relationship between birth control and that, right? And so, but if a doctor doesn't really care about it, they're not up to date in research, they're just going to hand it out like candy, right? Because that's what they were taught in medical school. And if they aren't interested in learning more about it, then they don't, right? So you also have to take that into account because a lot of doctors, coaches, things like that will teach what they're taught, right? Or do as they've been taught. And so if they're not staying up to date or being curious and continuing to research, then we don't see any changes, right? Like they're not like continuing to grow. The next thing is looking things up online. The risks of unreliable information here are quite high, right? How can we sort out the good from the bad? Who runs the site? Who is the organization? Who is the individual? Is the material reviewed by experts before it's posted? Where is it coming from? Is the information current and up to date? Are references appropriate and cited? Does it have facts? Does it have opinions? So how do you spot the bad info, right? Like, it sounds too good or too scary to be true sometimes, makes claims without backing them up without references, or, uses inflammatory language, uses outdated non-scientific info as a reference. And this is incredibly hard in women's health because it is finally just now becoming something that is being studied and prioritized. We are still so behind. And so we need to stay up to date. Like, this is why we're in mentorships, or we're reviewing studies regularly. This is why we're always taking new certifications. This is why we have different coaches going to different certifications, and like they learn something amazing. They teach it to the rest of the team. Like, this is why that we keep doing this, because things are always changing and growing and learning. And so this brings up another important part of this is like, where do you find information? How can you tell if it's based on real evidence or not? Like, who are these people working under? Who do they learn from? Who are they being mentored from, right? There is so much information out there and lots of places to find it. So we'll talk a little bit about where we can find that information, some pros and cons of finding it in places. But this is why I'm in literally 3 different mentorships right now, different coaches and doctors, 2 doctors actually, who are like huge in menopause, women's hormone health, part of the Dutch testing, like creation and everything, like people who are so big, because I think it's so important that like we are always staying up to date to make sure that we are doing no harm, that we are doing as good by our clients as we can, staying up to date, especially with like the surgence of new medications, different styles of HRT, all the things that we need to know, right? Because we have access to so much stuff, and people go to doctors and then there's just like all this different stuff and misinformation, and all the things are not up to date. which are causing people to feel really terrible, who are on HRT and they feel awful, who are on all these things, which I'm very excited to say that we're going to be working with a medical team right away here, which is super exciting. So you can do everything in-house. So you don't have to jump through different hoops and talking to a bajillion people. It's all streamlined. And we know that we're under the same umbrella, led by incredible, incredible doctors who are at the forefront doing the research on this stuff, which is super, super exciting. So Britt, let's talk about where we can find some information, some pros and cons of finding it in those, the internet.
Yeah. When we're doing our own research, where can we look for these things, right? Because inevitably we all go to Dr. Google and it scares the crap out of us because it's either everything's fine or you're dying, right? So we want to be able to kind of critically look at that information so we can discern what is actual, what is factual, what can I take to help back up my concerns, thoughts, desires, right? So websites, that's kind of the number one. We all have access to the internet. Pretty useful for current information, lots of various sources on there. Most often we're going to find specialized focuses on different websites, right? Some focus on this or this. So you can find very specific websites for certain things. Now, the limitations are that they may not be well designed. They may not be super reliable. They might be objective, right? They may or may not be authoritative in terms of evidence-based, and they should be critically appraised, right? So really kind of take it, but take it also with a grain of salt. Anything that, again, sounds like too good or too bad, you might want to go and double check. Can I find a study? Can I find a randomized controlled trial for this? What does that say? We can look at journal articles. These are also useful for most recently published research findings, and you can find journal articles on websites too. So, PubMed is a really great place to go for this. Limitations are individual study findings may not be consistent with other findings. And it can be hard to find the most relevant articles among that large number of journal articles that are being published. And again, this also does require some pretty critical appraisal too, because again, we have to ask who's writing this journal article, who's funding it, where is it coming from? That's the biggest thing I always tell people, look at the very bottom, who's funded that research, right? Because that's going to typically bias and sway that research. So
and we also have to look at can you read it, right? Because it's written not for the average person, let's be honest, right? Even myself, having gone through grad school and, done studies and written grants and all those things, still sometimes I'm like, okay, hold on. Let me read this line 17 more times to see what's happening here. And then also does it apply to you? That's a really big question, because you can read the studies of because you can find both fasting, very big, right? You can find so many studies that it is awful for you. You can find so many studies where it's really great for you. Does it apply to you and where you are based? Age, your hormones, any chronic conditions you're having, autoimmune stuff, right? There's so many other considerations that we need to see, okay, cool, that study found that, but will that be applicable to you and result in that for you? Because most of the time it is not, right? Because we're going to find the study that tells us yes to whatever we want to do so that we allow ourselves to do it, even though it might not be applicable to us, right? Because it happens all the time in coaching. So the next one is systematic reviews. Those are really useful for a good summary of all the available evidence that is happening right now, right? More reliable than findings from one single study. The limitations is that there may not be one that actually applies to your question, because we need X amount of studies before they can do a meta-analysis, and especially women's health. We're still working on it. We're still working on getting enough studies where we can actually do more meta-analyses, right? Then we have books. Books are useful for background reading and establishing a baseline knowledge. Limitations is that it's not always the most up-to-date information because things are changing all of the time.
We can also look at research that's in progress or unpublished. So this is useful for the most recent research, something that's an emerging finding, something that's kind of brand new, cutting edge, right? So access to these is less well known. It's well-funded research. It isn't always the greatest because it's brand new, right? And it may be useful to see research trends, but the limitations are like the quality of this research is often unknown at this stage. It's fairly, like we said, pretty low stage or very, very new. Research reports can be difficult to find or even difficult to access. You might have to look like conference proceedings to find this kind of information. Like if you've gone to a conference where they're, hey, we're going to release some new information that we are just finding, like that's where you're going to find it. So again, not very much information on it. We could look at protocols and guidelines, right? So useful for like officially endorsed procedures and practices. What, when I had a hysterectomy a handful of years ago, and they recommended a couple of different ways to have the hysterectomy. So what I did was I went and I looked at what are the protocols and guidelines for each type of hysterectomy that they're recommending. My doctor really pushed for one way. I chose a completely different way because I didn't feel comfortable with what I read, right? And that can be really helpful, especially if you're looking at like an official, like this is an official medication, or this is a procedure that we're recommending. You can go and look at what is typically done, right? This information might not be appropriate or even available for like the context that you're using, so it might not be something you can use. And you need to ensure that it's like the current protocols and guidelines for it too, because you can find some really outdated ones. And we can look at clinical tools, things like calculators or dictionaries. These things can be useful for determining accurate measurements and language definition, but they might not be specific, again, for your clinical need. So
then we have statistics. Everybody loves to throw out statistics, right? They are great for determining like trends, patterns for a specific population. However, the limitations are that it provides information on the effect, not the cause, which is something I have a struggle with because cool that we saw this effect, but what's causing it? Because if we can address the cause, that will help it so much more. So statistics are great. However, it's not enough, right? Government reports, useful for finding out what action the government has taken on a specific issue. It can sometimes include like a literature review or valuable background information. So like on efficacy, for example, however, can be out of date because they don't do them all the time. And then newspapers, useful for public opinion, which sometimes I don't want, right? Keep your opinions to yourself sometimes. But like limitations are that details may be inaccurate and or be guided by opinion or commercial political interest. And so this is like a really big one considering how things have gone in the last little bit, right? Like there's, newspapers will publish stuff based on who pays them, right? The stories, like all those kinds of things, right? So you have to be thinking about that as well. I will say though, that public opinion has been, we need more support for women's health. So that's been really nice, right? As long as the support that's coming is actually supportive and not doing more harm, which is not always the case.
That is true. We can also look at social media, right? And I think this is a really common one because I have lots of clients who send me things from like Instagram. They're like, what do you think of this? And I'm like, okay, so here's some
don't eat that. Don't eat that.
No, we're not going to go there. Have you ever thought of doing this? No, I have not.
Pretend you never saw it.
Yeah. Erase that from your memory and from your newsfeed. But social media we have to address that because that is a huge part in today's age, right? And there's a lot of information that is put out there on a daily basis. I have clients who come to me all the time and they're like, I watched this and they said this, but I watched this and they said that, and I watched that and they said that. And those are three different things. And what do I do? Right? It's confusing. So remember, when we are looking at social media things, like these are individual responses about very particular issues, trends in thinking. Like everybody jumps on this bandwagon and now everybody's making posts about this. And then all of a sudden, 6 months later, it's something completely different, right? And then there's usually like active discussions about that. So you're going to see a lot of back and forth in comments and stuff like that on social media. And really the big thing here is there's no quality control. You can say what you want. Right? Like we can say, if you stand on your head and, magically can balance on your head, like you'll lose weight, and people will be like, cool, let's try that. But there's no quality control for that, right? We can say kind of whatever we want and it's just kind of out there. And then colleagues, right? So this is useful for like a quick, convenient answer to specific questions at a very local level. What is somebody else who you are connected with, or maybe in a very similar state of body or state of mind as you? What have they experienced? Where have they gone? This is great for sometimes recommendations, or what was your experience with this person, this thing, this doctor? But again, that may not be consistent with the best available evidence, and it's going to be biased because that's person's opinion. So.
Mm-hmm. Exactly. So now I want to chat a little bit more in depth about another part of this whole evidence-based care, which is the informed consent part. This is just as important as having proper and correct medical information given to you. In the US, the doctrine of informed consent has been developed as a part of medical malpractice law. It is interesting that as soon as modern medicine came into being, people saw a need to address a patient's rights by law. We who hire doctors to advise and assist them with medical care have the right to receive full information from those doctors about our options and the risks and benefits of those options. We have the right to make the decision about which options we want to pursue, which that is a big one. A doctor cannot substitute their judgment for that of a patient by failing to disclose what she is going to do to the patient's body. The patient's decision to refuse a doctor's offer of treatment does not have to seem reasonable or prudent to the doctor or to anyone else. I want that to be very clear. The patient's decision to refuse a doctor's offer of treatment doesn't have to seem reasonable or prudent to the doctor or to anyone else. The right to informed and autonomous decision in healthcare is the right to weigh the full spectrum of the risks and benefits according to the patient's personal values and perspective. An incredibly important part here is that in law, coercion generally nullifies consent. Across jurisdictions, it is usually agreed that a person cannot be said to have legally consented to something if that consent was given under threat. Coercion can include the threat of harming the person if they don't consent, or the threat of withholding something that the person would ordinarily expect to receive. And so this is like a big one if like women don't want to take, maybe HRT is not something they want to take. That's fine. That's your decision. We're still going to help you, right? It's maybe they do want to. Okay, let's see if you're a candidate. And if it does no harm, then we're good to go, right? But I hate when women go to get support, specifically testosterone, which is a big one because studies do show it helps so much. Getting a woman on testosterone is like, why is this so hard? Or we had a woman who, this is one I'll never shut up about because it shook me so badly that I'm like, who is this person? Because she was having incredible symptoms. She's in her late 40s. She is having, she'd be a great candidate for cycling her progesterone, because she's having some pretty aggressive symptoms now that her hormones are starting to fluctuate. She's in her late 40s. Her doctor said she would not benefit from bioidentical HRT yet because she still has a period, even though her symptoms are insane. And he offered her birth control, which we know will make estrogen dominance worse, which is already what happens in your 30s and 40s in early perimenopause. And I was like, so you have no problem giving this person a synthetic hormone that we know is going to make the things worse and have negative long-term effects long-term, but you don't want to give her the real stuff, even though there's the risk is so low, the benefits are massive. Just because she still has a period, you got to wait until day 365 to be like, okay, now you can have it. Absolutely not. So this is the kind of stuff that I'm just like, this is why we're bringing everything in-house, because I am done with this crap. I am done. So done.
Yeah, it happens. That happens. It amazes me that they're okay. Doctors are okay with giving the birth control pill, which has 10 times the amount of hormones that bioidentical hormones would have, but can't do that because you're still cycling.
Well, and it's not to crap on doctors. That's not what this is about, right?
No.
There are some good ones out there, but
yes,
and they also have not been taught. Because this is newer information. So and again, if they're not interested in this, if women's health isn't their interest, a general doctor is not going to know this stuff. And so it's also just they don't know, right? And so I don't want people to be like, you hate doctors. No, I think that the medical system is broken right now and that I think there is a lot of work to be done. But also it takes so long for stuff to get to the front lines now, let alone be taught in med school and then be actually put into practice? And then what about people who've been practicing for a while? They're not up to date in that stuff. And so this is why it's just important to know these things and have this education. It sucks that you have to advocate so hard for yourself. But this is like part of why we do what we do, because I don't want you to wait 20 years and then be 80 and be like, oh, dang, I should have done that. Right? Like there's studies now that help support this. And so that's what this podcast and everything is all about.
That's the whole goal of this one. So kind of talking about that informed consent piece, which is really important. And again, something that we're not taught, that we're not really familiar with how to do. Like, what is informed consent? I want to know, like, what does this look like? So it really means to inform, right? So we're going to tell the person or the woman about what you observe to be going on at that moment with their health, with their labs, with what, their symptoms, with whatever is happening. Tell her about all the healthcare alternatives that are available to her. So not just the one that you think that she should choose, right? Just, hey, I think you should have the birth control pill. No, there's an HRT, there's nothing, there's this, right? We need to go through all of those things. And then tell her as much as you know about the risks and benefits of each alternative, and then what kind of evidence exists for that information. So this part of that discussion should be a transfer of these objective facts, and you should really, as a provider, leave your opinion out of it. This is like, okay, this is risk benefit option, risk benefit, right? This is not, I think, I believe, I wouldn't. This is just the information. And then there's advise. So telling that woman what you think that she should do, and then tell her why. So this is a really good moment to express like the limits of your own skills and knowledge, right? So like working with pregnant and postpartum patients, I saw this so much. It was crazy. But like if a client of mine wanted to have something done or wanted to do something in particular, and the doctor that they were working with had never seen it, done it, heard it, tried it, nothing before, I would rather them say, I don't have knowledge on that, right? As opposed to, well, no, that won't work. And then, well, why? Well, because I don't know. I've never seen it. Well, you've never seen it, right? So this is the time where you mention, I don't know. I have never tried. I don't have that knowledge. As coaches, we do this all the time. I know I've done that. I'm like, you know what? I actually am not sure, but let me get back to you with some research. Let me talk to one of the other coaches who has more information on that. We don't know everything. Neither does your doctor. And we don't ever expect that. So this is the advising part is the time to mention when you don't have that knowledge. And this is the part of the discussion that can be an expression of your actual subjective opinion about what you would counsel that person to do.
The next part of this is support, which is a wild concept, I think.
Wow.
Where we support the woman in the exercise of a decision between the alternatives. This includes a decision to not follow your advice. It isn't informed consent unless the patient has the ability to choose an alternative other than the one that the provider recommends. Informed consent is the bridge between evidence-based and human rights in medicine. The information is evidence. All patients have a right to be informed about the evidence regarding the healthcare alternatives available to them. The consent is the human right, the legal right, the constitutional right. Every single person has the right to informed consent. Informed consent and refusal. There is a discussion about the risks, the benefits, the alternatives, the option to accept or decline. Consent is freely given. Right to say no makes yes meaningful. Because if you're saying yes because you feel you have to say yes, that's not powerful. That's not consent. That's not helpful, right? That's not informed. So here's another area that is so important to understand, and it is so confusing. Informed consent versus the consent form. Often informed consent is confused with a consent form. In fact, informed consent is the willing acceptance of a medical intervention by a patient after adequate disclosure by the physician of the nature of the intervention, with its risks and benefits, and of the alternatives with their risks and benefits as well. The consent form only documents the process and the patient decision part. The consent form does not restrict patients' rights. It may be altered by hand, may be revoked at any time. I do not give consent. There are common violations, routine procedures presented as not optimal, or no information. And so The form is just like, oh, yeah, you're documenting that, yes, I'm having it done. Informed consent is not the signing of the paper part. It's the understanding everything. And I'll be honest, when I got my epidural, they're like, you have to read this to her so she understands all the things.
Yeah.
They're like, do it in between contractions. I couldn't even tell you a single word that was on that form except epidural. And so I'm like, this should have been given to us way before labor even started so that I could understand, because I was just like, I don't want to feel hurt anymore. But like, I can't even tell you one potential risk of the epidural. Because I'm like, this was not the time to make a good decision. Because in that moment, I'm emotional. I'm not in the right mind. I'm like, and Taylor's like, afterwards, he's like, oh, man, I was reading that. And I was like, are you sure you want to do this? But you were just like, stick the needle in my back.
Do it. Oh, man. Yeah. And it's very true. And I think that there's like that disconnect, because we think that if we've signed a consent form, we've been given informed consent. And that isn't always the case. So even the consent form and what they were going through, they were trying to give you informed consent, right? Trying. But like also, they're not great times to do that. Like, let's tell you, I can't tell you how many times during labor I was like, just is not the time right now. Like, literally. So yeah, that's why it is also important to have this information before.
Yes.
Right. So having that education beforehand is really where that can, because then you already know the risks and benefits. You've heard of alternatives, and you can pull those memories out when it's time to if you want to choose that or not. Right.
Yeah. Not a good time.
Yep. So, now we have kind of a better understanding of rights and what care should look like. I want to also talk about what is a common practice and what care can often look like. So you may have heard the term medical gaslighting. I know I mentioned it a little bit earlier in this podcast, but what is that exactly? So the definition of medical gaslighting is when a healthcare professional dismisses or invalidates a patient's concern about their health or symptoms, often leading the patient to question their own perceptions and experiences. So it is a form of emotional manipulation where the healthcare provider makes the patient doubt the validity of their own health problems. That's huge. And that happens a lot.
Oh man, the amount of women that I talk to who are like, I asked for this and they told me I was crazy and that I was like making a big deal for no reason. Like I had told them I wanted to have like my thyroid checked, which we're going to be able to do in-house right away, which I'm so excited. Because they wouldn't test more than TSH. And it's like, she has all the things and like you should be checking T3 and T4. And so then they checked their T3 and they're like, well, it's fine because you're on medication. I'm like, but did they check the T4 to see if like your thyroid's actually producing the T4? And like, they made her feel crazy and like she was being such a pain. I'm like, it's not even an extra blood draw. You can test all of them from one vial. So yeah, this happens all the time. So the first way that we see medical gaslighting a lot is through dismissal of concerns. Providers can sometimes downplay or disregard a patient's symptoms, suggesting that they are not real or not serious. Who has ever had that happen to them? Everybody raises their hands. This is like that Mean Girl scene when they're like, who's been victimized by
Regina George.
And everyone's just like, me, even the gym teacher. And I'm like, yes, even the gym teacher. So, for example, one study found that when men and women have the same symptoms of coronary heart disease, doctors were significantly less certain of a diagnosis in women patients, and women were twice as likely as men to have their symptoms attributed to a mental health condition. So they think we're crazy. Similarly, other research demonstrated that women with heart disease were treated less aggressively and were not well represented in clinical trials. So this is where you go to the doctor and you're like, I feel this, I'm concerned about this, I saw this on my lab work, I want to also have this and this tested, and then go, you're fine. Your labs are fine. You're just tired because you're a mom. You're stressed out. That's normal in this time of life. Oh, it's just menopause. Have you considered eating less and moving more? And you're just like, this was the biggest waste of time and I waited 6 months for this stupid appointment.
Yep. Oh yeah. Been there, living that one. So, Minimization of symptoms. This is another big one. So providers might attribute a patient's symptoms to stress, anxiety, or other psychological factors instead of actually exploring the physical causes of this. And it could also look like blaming the patient, right? Medical gaslighting can involve blaming a patient for their symptoms, suggesting that they are exaggerating or overreacting. I had a mixture of all of these things just happen to me when I was explaining something to my functional medicine doctor. And I told him it scared me because it felt like I was having a heart attack. And he actually laughed and said, "You're not going to have a heart attack." And it was like, first of all, we don't know that, right? Because you can't ever dismiss. And I was having heart-related stuff happen. But also, that is so minimizing. And then, he goes on to say, "You can't have that. You're totally fine. All your labs look great. How stressed out are you? Are you really sleeping?" And I'm like, you know what? No, we're not doing this. So it happens. It happens a lot. Even questioning the patient's memory or perception, right? Providers might question a patient's memory of their symptoms or just their understanding of what is actually happening to their body. Are you sure that happened? Are you sure that's the way it happened? Was it really that bad? They don't listen to the patient. They interrupt them. They laugh at the patient's concerns or suggest that what they're experiencing is in their head. There's a lack of empathy or sensitivity to the patient's pain or symptoms.
Yeah, or you get the whole don't confuse your Googling to my medical degree. And it's like,
yeah.
Man, that one just, and people say that and it blows my freaking mind because when things don't feel right in your body. And when you're not asking enough questions or digging deeper, it's like, look, where else are you supposed to go? It's so frustrating. And unfortunately, who is this happening to the most? Well, medical gaslighting is particularly common with women, neurodivergent individuals, and those with chronic illnesses, among other populations. How many of us fit multiple of those categories? Yeah, not a great situation, right? I can't tell you how many times we've heard doctors say, "It's okay that you have no libido. You already have kids anyways, and there aren't any other problems or issues." What? Or worse, they go, "Just have a glass of wine and then the sex won't hurt as bad." Excuse me? This is just a time in your life where you won't feel super great and you're going to have to gain weight. There's going to be hot flashes and stuff. It's menopause. It happens to everyone. You'll be fine. You'll survive, right? It's just you got to get through this phase. No, 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 no. Then we end up leaving this office feeling hurt, angry, sad, uncomfortable, and just honestly hopeless. And that is what medical gaslighting is, which most of us are like, damn, that sucks. And you're not the only ones it's happening to. It happens to literally every single coach who is on our team. It has happened to all of us, multiple points in our life. Brittany is in the thick of it right now, where we are literally reaching out to different places to get lab work assessed and stuff because it is so dumb. It is just, I can't.
Mm-mm. No, I can't either. Some of these things and it may not seem like that big of a deal when you libido, right? You're going in thinking okay, I have an issue with my libido. I don't have as much of it anymore, or I have a lot more vaginal dryness. It's really uncomfortable. So they should be able to take that information in and give me hey, use this moisturizer or do this or right. It shouldn't be that hard, but instead we're met with this, just have a glass of wine and you'll relax better. It won't hurt as bad. I'll never forget, I worked for an OBGYN and it was a woman. And the first time she ever said that to somebody, and my mouth dropped open in the room. I couldn't even hide. I was like, did you really just say that to her? And then she left and the patient was crying. And I'm like, yeah, this is not okay. So, this is a huge problem. And since we typically go to the doctors to seek this guidance, we seek support, we seek answers for them. And if they're not listening or hearing us, and if our experiences are being minimized, and if we're not being given this evidence-based information so we can choose a best possible treatment, then we can see some consequences that happen eventually in our life, right? Things like delayed or missed diagnosis. Like when a healthcare providers don't take a patient's concerns seriously, it could lead to delayed or misdiagnoses, like potentially worsening of your condition. So me personally, like I had to call an ambulance a few months ago. I thought I was having a heart attack. Luckily, I was not. But the lack of responsiveness to that due to my age and my gender was appalling. I was told, don't worry, you're too young and you're a woman. You're not having a heart attack. And like, while I appreciate like hey, you're healthy, you're 42, you're a woman, like this is pretty uncommon. The fact that I was having heart-related symptoms bad enough that where anybody knows me, I'm like homeopathic, rub some dirt on it, you're fine. Like,
And don't ask anyone for help.
I don't. Yeah. So when I wake my husband up and I go, call 911, like that's a problem. So that was a concern of mine. I sat there wondering, am I actually having something happen? But I'm being so dismissed about it that I could be putting myself in danger later on, right?
And there's going to be damage to trust too, right? Like it can totally erode a person's trust in the healthcare system and makes them less likely to seek care in the future. That's where I am. Like the fact with my mom and how she ended up, that like I pushed so hard for her because like she was the most active woman and then went from one day to the next not being able to go up the stairs without having to take a break because she was winded. They told her it was asthma and gave her an inhaler. And I was like, there is no way. And so I pushed and pushed and pushed, ignored. 6 months later, took her to the hospital because in 2 weeks she lost 20 pounds, couldn't eat anything, was in immense pain. She had tumors all over her body. She had one that had collapsed her left lung, which is why she could not breathe, because she had a baseball-sized tumor on her left lung and she had liver or colon cancer before that. And I said, check liver and lungs because that's where that cancer spreads. And they said, that's so unlikely. And I said, I don't care. I'm not leaving until you do something. I was not kind that day in Emerge, and rightfully so. From that day, like she never left the hospital. Like she was gone 3 weeks later. And so I have a massive distrust for this because it was multiple doctors who did not take our concerns seriously. And like, it's just insane. And so that's an extreme case, but it's like, if they would have addressed her legitimate concerns of like struggling to breathe now, but because she was quote unquote healthy, and like not like at a point where they're like, oh, well, you're still able to like, you're sitting here, your heart rate seems fine. No, like she has a legitimate concern and you sloughed it off. She could have still been here for all I know. And so, yes, that's like an extreme case, but also like that's where things can end up. And like, just because you're maybe it is libido, maybe it is like night sweats, that still matters because something is causing it. Usually it's hormonal, but we know if hormones are out of whack for a long time, that can lead to other negative consequences. There's a reason why women post-menopause now start experiencing the same level of risk or greater than men for anxiety conditions, for cardiovascular disease, osteoporosis, all these chronic conditions that before that they didn't. So hormones matter. And that's the kind of stuff that drives me insane. And then you add on top of that emotional distress where, being dismissed by providers can lead to feelings of frustration, anger, depression. It stops you from wanting to ask for help. You start to isolate. You start feeling lonely. You start thinking you're crazy. That has a massive negative impact on your mental health. Medical gaslighting can make existing mental health issues and conditions even worse or even lead to the development of new ones. You might spend a long time attempting to find a doctor who can accurately diagnose your symptoms, which can lead to excessive testing. Britt's going through that right now. Frequent visits to medical professionals, taking time off work for that, misdiagnoses that need to be corrected because people are on things that should have never been on in the first place, physical pain, suffering from the failures to address a medical condition with appropriate care. And unfortunately, the frequent visits to different doctors starts to make you look less credible because they'll look up and be like, you went here and you went here and you went here and you went here. So then doctors already go in thinking that you are a little bit crazy. They believe you less, even though you're just trying to find someone to take you freaking seriously, which is so freaking frustrating.
It is. And so, you're probably listening to this and you're like, yeah, I've experienced this and I'm going through that. But like, why does this happen? Right. And, again, just like we said before, we're not here to say poo-poo on doctors or anything like that. Right. It's Probably not intentional, at least for a majority of providers, because there are really great doctors out there, right? I know for a fact that most doctors have had about 6 weeks of training and education in nutrition. That's not very much, if that, if even 6 weeks, right? Most of them have never had any additional knowledge in training of with hormones, pelvic floor health, that's a huge one, sexual function, perimenopause, menopause, or, other than like maybe the chapter that they read about it in medical school, unless you are somebody who has chosen that field as a specialty, right? Like you have now decided like, I'm going to become a menopause specialist, or I'm going to become a pelvic floor specialist, right? And research has shown that the United States National Institutes of Health have generally overfunded research on disease that primarily impacts men. And it has underfunded research about diseases that primarily impact women. So as a result, medical professionals aren't as knowledgeable about women's health issues, their needs, and the treatments for them. So, we see doctors' biases come into play, and this is where having that evidence-based care can be really, really helpful, and it's really important. It eliminates the bias. It relies on that communication, the evidence, and just working together with the client.
Yeah, it's something like 80% of like OBGYN, medical, I think it's 80% of medical residencies feel like they don't have enough information or knowledge or confidence to treat perimenopause and menopause. And it's like only 20% of OBGYN residencies even like teach on perimenopause and menopause. It is a surgical residency. It is a residency on babies, basically. Pregnancy, having babies, that's it. Like it's slowly starting to change, but again, it's going to take time for that to come out, which is like frustrating, but here we are. Even I have doctors who are friends who are OBGYNs, and they tell me this. They're like, yeah, it sucks. We don't know anything about that. We don't. It's babies. That's it. So what can we do to try and help prevent medical gaslighting? Because you're going to come across it, right? So the first one's obviously going to be like finding a doctor that you can trust. Ask other people you know for recommendations, read reviews, and find someone you feel comfortable talking to. Bring a family or friend with you. This not only helps you have two sets of ears and eyes, but this person can also back up your symptoms, remember things that you may have forgotten, or ask questions you do not think of yourself. More information is always good. This is why we hired a doula when we had a baby. This is also why my husband came with me to all my appointments, because I am very good at advocating for other people. As you can tell, right. I have no problem being like, nope, stop, absolutely not. Like, let's listen here. When it's myself, I'm like, yeah, oh, I'll be fine. Yeah. Just like, who am I? And so my husband, I'm like, okay, this is what I want to say. This is what I want to ask. This is what I want to have. Like, here we go. And he's like, okay. So he has his list. And then he advocates for me because I have a really hard time advocating for myself, which people would never believe, but it's true. And then write down those questions, those symptoms, the notes to bring down, bring them in. Like we help clients like be like, this is what I want. These are the tests that I want. This is why. We help them prep for their stuff. Luckily, we won't have to do that anymore because we're going to do everything in-house, which is so exciting. But it helps you bring in a clear, concise thoughts, questions, concerns, allows you to track anything that changes with any changes that you are making in treatments, medications, those kinds of things. And always get a second opinion if you need. Like if you don't feel understood or hear that it's okay to get another opinion, right? Like you are allowed to do that. You should do that, especially if you're seeking someone who has a specialty in something like going to see a menopause specialist after seeing your GP, endocrinologist, all those things, right? Like it's never a bad thing to ask for a second opinion and ask questions. Some doctors might not like that, but it is your right. And I really do think that you need to advocate for yourself or have someone with you to help you through that.
Yeah, absolutely. So the last thing that we're going to touch on are, because we've mentioned it a couple of times, are labs. Because labs, we're always told, oh, that looks normal. That looks normal. You're fine. Everything's fine. Your labs look normal. And we want to talk a little bit about what's considered quote unquote normal. So oftentimes you will have your doctor run labs when you're kind of feeling off. They come back, your doctor calls and says, oh, everything looks normal. Okay, you're fine. But you feel anything but fine and normal, right? So remember, there is a very different level of normal or clinical labs versus optimal labs. So lab values are created based off the average of the population, which is why that range is so wide, right? It captures people who are very low or very high within that range, and it captures some of the unhealthiest people in the population.
So we're not healthy as a population. Let's be honest. So like the
not.
average of the population is not great. Let's be honest.
It's not. So, functional levels, or what is considered like optimal levels of labs, focus on a more narrow level of lab results that are meant to like optimize your health and even identify imbalances that are there preceding a disease, right? To help you prevent, right? Prevention, developing that disease in the first place. So clinical ranges can often miss early signs of these issues or these diseases. So remember, normal does not always mean optimal. So if you're feeling off after you get your testing back and you're given the quote unquote all normal, then it might be a really good idea to compare your testing ranges to functional levels, or again, get that second opinion from someone who does look at functional levels.
I mean, we see this all the time with like, again, thyroid labs particularly, blood sugar labs particularly, like they're like, oh, you're normal. I'm like, you are 0.1 away from being out of the low range. And normal, like we mentioned, is not based off of a healthy average population. And so it's low. It's low, or blood sugar is high, right? And so, but they can't give you anything to treat it until it's out of that range. So they will tell you it's normal because they can't give you the medication, the script, until it's out of that range. We don't want you to have to take that script. We want you to get your levels optimal in a place where you feel good, your body is functioning well, which also will allow you to lose weight, right? We don't want to wait until it's so crappy that now you have to go on medication just to feel somewhat better, but we're never addressing that root cause anyways. Like half the time when we see that like T3, T4 is off, it's a conversion issue. It's not that your thyroid can't produce stuff. Usually we see an imbalance. We're like, oh, it's because you have so much inflammation in your body from your gut health or your liver or whatever it might be. That's why. Like your thyroid is actually fine, but we need to address the root cause. But no, we can't do anything until that range is out and then you get that medication, right? And so this is where I want people to really understand that normal labs, like, if you don't feel good, things are not normal. And normal is also not healthy right now. So we need to improve that. We want to be optimal, right? And so I know this podcast was a long one. I knew it would because we had so much to cover in terms of like, what is evidence-based? What is medical gaslighting? The normal test ranges, how to advocate for yourself. And so I hope this was helpful. I really hope that you were able to get through all of it. I hope that you share it with other women. If you guys have questions, please reach out to us. We do the free consultation calls on purpose because we know it's so hard to get someone to look at the full picture, your symptoms, your history, and give you some idea of what is likely the root cause. What are the things that you can start implementing today that does not have to be a medication to start feeling better, to optimize your health, to understand your body? Because when it's not feeling right, when it's not working properly, we feel, we're so hard on ourselves and we're like, I'm so broken. I'm so vulnerable. Like you're hopeless. You're just so frustrated and overwhelmed. And that's why we do the free consultation calls. We get a lot booked. I'll be honest, we do a lot of them. So I think we're booking like 3 or 4 weeks out right now, but we do this on purpose. Maybe when this comes out now, it'll be a little bit later. So maybe there'll be more, but please book those. Like they are not sales calls. They are simply helping fill in the gap that we see needs to be filled. We don't charge for them because we don't think it should be this hard to get someone to look at everything and give you some answers, right? And so is it lab work? No, but it gives you a very, very good idea as to what is going on and have someone actually listen to your concerns seriously, right? And then from there, we give you the guidelines. If you want to talk about coaching, that's a totally separate link. That's a totally different call. So you don't have to worry about like trying to get sold into anything. This is literally just filling in a gap. This is why we do what we do, because we see there is just a gap that needs to be filled right now. So if you want to book one of those, they are in the show notes for you. It's the consultation calls there. But if you have questions, please reach out. I will always answer. Sometimes there'll be a delay because a lot of you ladies reach out, which I love and I never want you to stop doing. But if you need anything, please let us know. Help us help you. This is our biggest mission. And we want to just see everything change and, change the trajectory of women's health. So we love you so much and we will talk to you soon. Bye.